All right. Hi, everyone. Thanks for joining me today. My name is Colin Gundling. I'm a physical therapist with Alliance Physical Therapy, and I was we put together this presentation to discuss osteoporosis specifically, and more generally, we'll definitely get into some fracture risk, types of fractures that are important to consider in these cases, and then also what we can do to minimize risks here, because this is a big results in some pretty severe morbidity and things of that nature as you if it tends to occur as you get older. So I'm going to share my screen here. Let's see. Share this one, and then we'll share a couple different things. So this out of our way. Okay, so this is kind of the little presentation that I put together on osteoporosis specifically. The biggest things to consider here when it comes to osteoporosis are fractures, right? So that the osteoporotic changes can result in fractures occurring in the population, and this is something that once these fractures happen, we are definitely at risk for a lot of worse things happening. It kind of can create a downward spiral for a lot of individuals. So talking about fractures, oftentimes we talk about, you assume as someone fractures their hip, it's because they fell, landed on their hip, and it resulted in a fracture. However, with osteoporotic changes, we actually find that sometimes minimal is needed to result in a fracture, whether it's in the neck of the femur or in the segments of the spine or in the wrist. A very minimal trauma is actually needed to have a fracture. So a reasonable question to ask sometimes is this a chicken or the egg phenomenon? Does the fracture happen as a result of hitting the ground, or does the fracture happen and then the patient hits the ground because their femoral neck just gave way? Say they're going down the steps and they take a little bit of an awkward step and it just gives way and you go down. So it's a reasonable thing to discuss and ask. Just because a fracture happens doesn't mean that it happened because of hitting the ground. It could have been resulted in the person hitting the ground. From a management point of view, that tells us that it just highlights to me and illustrates to me how fragile these bones can kind of get when it gets to a point where those changes have gone pretty far down the path. So you definitely need to take this seriously, because just being safe and avoiding falls and avoiding any situation that puts you at risk for falling might not be enough in these cases, because sometimes it could just be that the bone literally gave way on you. And so getting deeper into this, like what causes this bone mineral density to decrease and what are some of the comorbidities that come along with it, is the first thing I want to do. And then I want to talk about the disease from an activity point of view, right? So saying up here, movement is medicine. So I have in here some of the common prescribed medications and things, but that's certainly outside of my area of practice. My area of practice is movement. So I want to discuss what people can do to move to help their bone mineral density, help minimize those changes that result somewhat inevitably as we age. So the first thing to realize is that starting with more density is better. It sounds pretty obvious, but basically the bone mineral density you lay down throughout your adolescence up till your late teens and early 20s is basically what you have. So if you are doing a lot of weight-bearing activities, a lot of resistance training, things like that as a younger individual, then you're probably going to have less risk for osteoporosis as you get older. Same with your diet. If your diet is a good, healthy, well-rounded diet, then you have less risk. If you have eating disorders or other things that may result in your bones not being able to absorb calcium quite as well as when you're younger, then you're going to be at a higher risk for these changes in density, these negative changes in density as you get older. Super important to educate our young people on this and how it is to make sure that they're active and they're moving and they're They are eating healthy and things of that nature for so many reasons. But this is one that they wouldn't see until years and years and years down the road. So it's kind of hard to wrap their brain around it, maybe. Teenagers have trouble thinking till next week, let alone 50 years in the future. I know I did, at least. So moving on to the epidemiology, which is a word that I'm sure we've heard a lot recently with COVID, but basically just kind of the history and of the disease, and what we can look at a population and how that disease affects a population. That's the epidemiology of a disease. So in people that are greater than 50 years old, 1 in 5 men and 1 in 2 women will suffer an osteoporotic fracture. So that is pretty significant, if you ask me. That's something that really tells us that this affects just about everyone. I mean, that's not even saying these people have osteoporosis. It's just that they actually have had a fracture as a result of it. So it really affects everyone. And we know, like I said earlier, those hip fractures are the result in some of the highest morbidity and mortality of any fracture in the body. In fact, it is the highest morbidity and mortality in the older population. So we know when people have hip fractures that almost 50% of them will require long-term care afterwards in the elderly. So they just, if they have a fracture, they don't go home. They go to the hospital and end up in long-term care. They have, and even up to 20% in the next 6 to 12 months after fracture have a risk of dying from as a result of complications from that. So it's something that we take very seriously in physical therapy, especially because we believe that we can have an influence on this and help people avoid it. And it is hard as a physical therapist to rehabilitate someone after a fracture. I've done it successfully and unsuccessfully at times, and motivation is always a big factor, and just generally it kind of, like when somebody's hospitalized, from what I see, it kind of gives their comorbidities a chance to catch up to them. So they might be generally relatively healthy, but they have some comorbidities that they're just managing as an elderly individual. They're hospitalized and are in the hospital for a week or two, and then everything kind of catches up and things kind of can start that downward spiral, much how COVID has affected people also. So it's something that we want to avoid if we can, and there really are some ways to avoid those hip fractures. One thing that's interesting, if we go somewhat out of order, but if we come down to the diagnosis, so it's based upon a bone scan or a DEXA scan. Your T-scores, if you have osteoporosis, it's negative 2.5 or less. Osteopenia, which is like pre-osteoporosis, is -1 to -2.5. However, it's estimated that fractures, almost 50% of fractures that are caused as a result of bone fragility in women are when they're still in that osteopenic state. So they're not even at osteoporosis yet. So just because you don't have osteoporosis yet, you still have an elevated risk for fracture. So it's not like a binary thing. It's not, okay, when you switch over to having less than -2.5 on your bone scan, now you're at a risk for fracture. Really, you're kind of always at an elevated risk as you drop down below that 1. So that's something that is important to just keep in mind when we're looking at those risk factors. So comorbidities, rheumatoid arthritis is a big comorbidity. Generally, diseases that limit mobility, so Parkinson's, MS, things resulting in you just not being able to get around as well. Because we know that getting around, doing weight-bearing activities, can help slow that progression of the bone mineral density declining. So that's something that we really want to be mindful of and find ways to help people move with these conditions. Another one that I put on there is vertigo. This is a little bit of an outlier, but it falls within our scope of physical therapy, and it's something that, as I have actually been looking for it, I see it more and more, and that is with vertigo, a specific type of vertigo called benign paroxysmal positional vertigo, which is basically when you have crystals in your ears, they're called otoconia, that get out into these canals, and they can cause severe short-term dizziness. So super severe room-spinning dizziness that only lasts like 20 to 40 seconds, and then it's gone. But then you get up and turn your head again, and it happens again. It's something that is very reasonable to treat in physical therapy, but it is something that your risk for it increases with age and with osteoporotic changes, and that's because those otoconia, those crystals, are made of calcium. They're basically little bones, and if you have lower bone mineral density, those start to break down and break off of one another more easily, and they get to places they shouldn't, and then that results in vertigo. And think about, vertigo is a balance issue. It throws your equilibrium off, so you're not as balanced. So then with that, your risk for falls will be elevated. Sorry. So these are things that we can't ignore. We have to make sure we're looking at this. Okay, sorry. We're looking at this individual globally to make sure that they're able to rehabilitate fully from their issues. And generally, we expect the population to become less active over the course of the upcoming years and decades. So with less activity, the risk for osteoporosis will be increased as well. Now, there are some, if you're wondering about your own risk for osteoporosis, there's a tool called the FRAX tool, Fracture Risk Assessment Tool, and there's a website that we're going to go to here that we can discuss that a little bit more. So let me pull this up here. Okay, I can't tell. Okay, I think sharing, yeah. If you can't see this tool on Google Chrome, then let me know. Can't see it, maybe? I can't hear you, sorry.
Oh, sorry. It looks like we can't see the video. Can you try resharing your screen, please?
Yep, let's try again. How about that? Any better?
Still not seeing it.
Oh, man. Okay.
Sorry about that.
No, it's all right. Let's try from here.
There we go.
Oh, okay.
Yes, we got it.
All right, nice. So this tool is, if you just literally type in Frax tool on Google, it'll come up. And basically what you do is you put in you answer all these questions, and it'll give you a risk for fracture. And it's really useful, especially for those in our population that kind of are on that cusp of whether or not it's a concern. Now, you don't need to put in all this information. Like, you might not have these scores here, but that's okay. It can calculate without that. And this is something that if you're just curious, I would encourage you to go look at this. Then your risk factors, this is a nice kind of grid on what your risk factors are for osteoporosis, like if you have rheumatoid arthritis, consuming more than 3 drinks of alcohol. All these things will calculate your risk factors for fractures specifically. So not necessarily osteoporosis, but fractures. So this is a really useful tool for us as we get into, as you kind of become curious about what's going on for you specifically. So if we get back to my Word document, I'm going to just share my whole screen. Hopefully this will work, because I just want to be able to jump back and forth. Good? Okay. So thanks. Okay, so we're going to kind of move our way down. So common fractures with osteoporosis include hip fractures that we already talked a lot about, and I'll probably talk more about because it's a big deal. Thoracic spine fractures, which are compression fractures of the vertebral bodies of the spine. They can sometimes occur from just bending and lifting, kind of twisting in funky ways. And that's something that's concerning because it's not really a traumatic event that can make it happen. The good thing about thoracic spine fractures is that they don't cause a lot of morbidity and mortality in those individuals. There are some surgical procedures that can be done to help with basically reform those vertebral bodies, but from my understanding of them, they are not as commonly done because the success isn't great. Usually we just kind of let it heal fractured and then just get it moving from there. But that's one reason as we look at older individuals, they might be a little further bent forward. And then think about how, talking about how like vertigo being associated with osteoporosis can increase the risk for falls. So if somebody is bent forward more, then their center of mass is in a different place and they might be more likely to trip and fall and have more momentum going forward. So all these things are things that we have to consider having a relationship with each other. Wrist fractures, another common place, just reaching and falling. They don't even have to fall hard, and that could result in a fracture in the wrist. So those are the three main areas with osteoporosis, but there's all kinds of different areas that we can identify. And I've seen high level running athletes that have like their pelvis fractured as a result of having osteopenia. I think they were somewhere at like around -2. So they're kind of the lower end of osteopenia, headed towards osteoporosis, but they were like a world-class caliber athlete that had some issues there, which is really interesting. So that gets back to, it certainly wasn't their age. It was more like as the body breaks down, it wasn't able to build back up. So yes, as we stress those bones, it results in breaking down that bone. But then this individual didn't have, whether it was the diet or their rest periods or what have you, didn't give it the opportunity to build back up, and that resulted in those fractures most likely. Then moving down to the medical management, because we already talked about the diagnosis. Medical management, this stuff again, I'm certainly nowhere near an expert on this, but if we look at it from top to bottom there, we're just kind of looking at the typical order that I've seen of management. So starting with the bisphosphonates, and then those are an oral or injectable. Then you would move down to another injectable, and then considering hormone therapy. Typically with the females, estrogen therapy may occur on its own in isolation from some of these other drugs. But with the males, my understanding is that testosterone supplementation would be with some of those other drugs typically, just because of how things are operating differently from a pharmacological point of view. And then bone building medications, that sounds good, right? Like this is probably the biggest point I want to make here. Like, wouldn't you rather have a bone building medication than something that's just kind of maintaining your levels? Yes, but it is the side effects from those are significantly more than the side effects from some of these other things. So you have to consider the costs and the benefits in there. Now, one bone building treatment that has been shown with minimal side effects to rebuild bone is exercise and activity. So there we go. There's my segue. The activity levels can significantly increase our bone mineral density, but all activities are not created equal. So we need to make sure we kind of discuss this a little bit. Now, something that I always talk about, and like another talks about general exercise, I'll discuss this for sure, but our body in general, from musculoskeletal system all through, responds well to stress when it's applied in a slow and diligent manner. It does not respond well to stress that's applied really quickly. So an example of stress applied quickly is a fracture of your bone. Like stress happens fast, it just can't resist and breaks. But if you apply that stress slowly over time, that bone density actually increases, and that's what's called Wolff's Law here. So Wolff's Law is specific to bone density, but we can really see this all around the body. And the best way to visually see it, which I think helps us understand this, is the difference between a callus and a blister. A blister is that load applied really fast, resulting in the skin just tearing away and becoming injured and painful, versus a blister, even though they're not maybe the best, most comfortable things sometimes. It is a really nice adaptation for someone to have if they need to spend time walking a lot on rough surfaces, or runners have blisters on their feet. So that skin thickens and becomes harder and stronger to resist that stress. So that's essentially what happens in our bones with respect to this talk. Our skin, it happens in our muscles, it happens in our tendons, it happens in our ligaments, it happens all across that like bone joint kind of orthopedic system. And so it's something that we need to keep in mind when we're applying these exercise principles, because too much too fast, especially in these populations that are at risk for fracture already, would be kind of a devastating mistake to make. So we don't want to do that. We want to make sure we apply slowly and in a graded exposure to the activity. So you have to consider what that person's starting with to determine where you start them and how far you go. So that's an important thing to understand. I think the visual really helps. Now, if we're going to talk about specific types of exercise, the most common cited type of exercise for individuals, especially as you get older, would be walking. So walking is always looked at as, oh, that's great because it's a weight-bearing exercise. That's something that is recommended to minimize the osteoporotic changes and things of that nature. So that's something that and it also helps minimize cardiovascular risk and things of that nature. However, as an isolated intervention, walking does not increase or does not actually modify the loss of bone mineral density. So it's not that it doesn't increase it. It's not that it does. It's actually that it doesn't really even slow it down. It kind of continues to decline, sadly, because that would be nice if that's all you needed to do. But you really need to add more in, and this is the soapbox that I get on for a lot of different reasons, but this is one of the best ones for bone mineral density, about doing more than just walking as your exercise as you get older. And for individuals that are older, not being afraid of the weight room and trying to move some heavy weights and challenge yourself, get out of breath. These are things that we should be doing. And unfortunately, we tend to shy away from them because we're afraid of things. We're afraid of falling. We don't think as we get older, we don't need to, we don't need to worry about our beach bodies anymore. We just want to live our lives. But unfortunately or fortunately, doing this improves your mobility, improves your ability to get around, and decreases that slide towards less dense bone minerals. So this is something that when we talk about training, walking is great, but adding in some high-intensity training is good too. So high-intensity means something, it's not necessarily running, which is good. Running is good for sure. It's better than walking for bone density, but you might not be a runner or you might not be able to run. But high intensity of going up hills, like walking hard up a hill, fast up a hill, getting on a bike and really turning up the resistance knob and pushing down through that, getting your cardiovascular system taxed. These things would be included in that, or on like a stepper machine too, or going upstairs. These things would all be kind of included in that high intensity aerobic training, which is something that I would definitely encourage everyone to explore if that's something they haven't done. And they can do it in, you may have heard of like high intensity interval training. It's called HIIT, H-H-I-T. And they have HIIT classes that are designed specifically for older populations. So they build slowly, but they do get relatively intense. And that's really important. Interval training means you train hard, take a break, train hard, take a break, train hard, take a break. So when you're training, you're into it, and then you get a nice long break. Into it and get a nice long break. Aside from your bone mineral density, this increases turnover in the muscle, increases the youth of your muscle tissue. It has like a lot of benefits to really consider. Now, HIIT training also includes some resistance and strength training, which is really where you get the most out of the exercise programs for minimizing bone mineral density loss. That the most effective thing that you can do is weight training. So, and it's site specific too. So that's something important to consider if you have, somebody identifies femoral neck, like they do a scan on you and you have femoral neck, you have osteoporosis in the neck of your femur down by your hip, then doing bicep curls isn't going to help it. You've got to do like leg loaded exercises. And then vice versa, if you have osteoporosis in your distal ulna, you need to do something wrist extension or weight bearing through your wrists to help with that. So those things need to be considered. It's very site specific. And it takes some time. So it's recommended that you probably won't see huge improvements until you're almost a year out of doing this, and you're doing it 3 times a week. So it's something that can take a little bit of time to build up, but it's not. You've got to look at it as it's not just to benefit your bones; it's to benefit everything. So it helps a ton with all parts. And then we've got to make sure it's progressing and advancing and challenge. So I'm going to show you like an example program here in a moment, and we'll see how that challenge improves. Another thing to consider is your balance training. So like I said earlier, is it the chicken or the egg? Does the bone fracture first, or do you fall and then fracture the bone? Balance training is a way to prevent falling, and we know that this is a big topic and something that is very important to discuss. And in fact, I've done a talk in the past, and maybe we can do that maybe even next, specific to balance training and how we can just understanding how your body balances and what are some of the most important things for maintaining balance. And really, the most important thing is strength. So if you don't have strength in your lower legs, then you are at a big risk for falls, no matter how good all the other systems that you have available to you for helping you balance are, such as your visual system, or we talked earlier about your vertigo, so your inner ear. Those systems don't matter if you're not strong. So you've got to be strong. And another type of training that has been shown, so balance training doesn't increase your bone mineral density at all. What it does is decreases your risk for falls, so it decreases your risk for fractures too. Then a vibrating platform training is a kind of a unique thing, but actually does have some evidence to support increased bone mineral density. I'm not sure of like the dosage with that. I'd have to look into that, but it's something to consider. Usually, like from my perspective, I'd have to like compare everything side by side, but I'm kind of hesitant with anything that seems like a little bit more of a passive exercise, which a vibrating platform seems a little more passive to me. So because people tend to want to replace that with all the other stuff that's better that they should be doing. So an example is, and maybe we talked about it last time we did the talk, but using glucosamine chondroitin supplements for arthritis. Those are not really shown to be effective for lower body arthritis. But even if someone is using them, and maybe it is for them, so maybe they're in that 5% that it is, but they can't use it to replace all the other stuff that's definitely effective, like exercise and the harder stuff. Like, we don't want to just try to solve the problem with a pill when we know everything, all this stuff over here is helpful. So to me, those vibrating platforms are kind of more of like the pill, where it's like easy to use, easy to get on, and probably a little too easy. But if you're doing all this other stuff, the high intensity training, the resistance training, the balance training, and then adding on that vibrating platform, yeah, that would probably be really good, just to kind of add round the whole mix out. But doing it all in isolation is not is probably not as effective. So let's talk about the Okay. Can everyone see the Google? Yep. Okay. So this is out of a study where they put together, it's called Osteosize, which is a kind of a clever name, but they put together a 12-month training program because it does take 12 months to see these improvements. So if you look over on the left-hand side there, you can see the phase 1, 2, 3, 4, 5. And then you have the weeks within those phases. So weeks 1 to 2, 3 to 4, and down that chain all the way up to a year. And it gives you some information on what we expect these phases to be. So orientation for those first 4 weeks, just understanding movements. Remember, we want to start slow with this, recognizing that maybe not everybody is starting from the same point, but this is a study, so it tries to control all the variables as much as possible. So for the purposes of this study, everybody will start from the same point. But they have then they move on to intensity. So RPE, which is rating of perceived exertion. Basically, this is a 0 to 10 scale, I believe. Sometimes they do it 0 to 20, but I think this is the 0 to 10 version. So 0 to 10, 0 being sitting, like sleeping, basically, and 10 being something you can only maintain for 10 seconds. So 3 to 4 for this first phase, and it gives you the sets, the reps, the speed, so everything is done slowly, giving you appropriate rest. You have high velocity exercises, impact exercises, and functional training. So we're kind of functional training is the balance stuff. Impact exercises would be get progressively more aggressive to jumping activities and things like that, but it might just be stepping up activities, stepping down activities, things of that nature. And high velocity progressive resistance training is something where you are using so if it's a bicep curl, you pull that weight up to your shoulder quickly and then down a little more slowly. Pull up quickly and then down slowly, and that's been shown to have some beneficial influence on bone mineral density. And you can see how as we go through this year, everything just gets harder. More reps, higher intensity, higher velocities, but it's not a steady increase. You have times where it increases to get harder, and then it gets a little easier. Increases to get harder and gets a little easier. And that's a cyclical training schedule that can result in not overtaxing the body, giving it an opportunity to heal, kind of like how that running athlete may not have done, and resulting in those pelvic fractures that may have occurred. So this is a good general schedule, but I wanted to kind of show this to you to show how it does progress, but it's not linear. There are ebbs and flows to the progressions, and it takes some time. It really does take some time to see significant gains here, but it's something that you do have control over. And another thing that's important to note is that it's not something that is just for osteoporosis, right? Like, this is a really great training schedule for anyone, not just because you have osteoporosis. That might be another good reason to do it. But this training schedule will benefit you in so many different ways. So trying to get into something, you don't have to do exactly this, but trying to get into something similar to challenge yourself and progress yourself. And this is something that a physical therapist can start you out with, like give you some ideas and give you some pointers, and then build you into that over time. So this is something that's very much in the realm of a physical therapist practice. But as we wouldn't see you for like 3 times a week for 12 months. We would see you here and there initially to get you an understanding and oriented to the movements, and then we may either turn you over to your own self-management with some check-ins every once in a while, or turn you over to a personal trainer that has a good understanding of exercise and exercise how it's used for treating medical conditions. So that's something to consider for sure. All right, I think that was everything I had to go over specific to balance and, or sorry, not to balance. We could do that at another time. Specific to fractures and osteoporosis. So can kind of open it up to questions to see if anybody has anything that they'd like to have answered. Or not? Okay. If not, that's fine. I can let me throw my email in here real quick so that everybody can have that. then you can shoot me an email with any other questions you might have. And
Colin, I have a question for you.
yes,
Can you hear me?
yep.
So how do you get started on something like this? If you were interested, do you have to go to your doctor and get referred to a physical therapist? Can you just go to the physical therapist and say, I have some concerns about this? Can you give me a program? Where would you go to get started?
So that's a great question. Most physical therapists, and that's us included here at Alliance, the majority of us have our direct access license. So you can come straight to physical therapy and we can start treatment. Somewhat depends on your insurance. With some insurances, we immediately would reach out to your physician and let them know that you're coming and get some agreement and some signatures from them. But generally speaking, unless you're coming for an auto accident or a workers' comp, we can see you and at least initiate your care, and then we can kind of handle it from there.
Thank you.
Sure. So I threw my email in there, so please reach out with any other questions that you might have. And this is kind of, as you can see, there's a lot of different parts of this topic that we could jump off into. Exercise prescription specifically, like just understanding exercise for your own good better, is one that I've done a lot of discussions on, and then balance is another big one that we've done a lot of discussions on. Those are two big things that, especially as we get older, people tend to shy away from some of that stuff because they're afraid of falling and hurting themselves. But in a way, they're hurting themselves by not doing it. The challenge is just making sure we're doing it as safely as possible, and that's where some guidance from a professional can be helpful. It doesn't necessarily have to be a physical therapist, though I'm kind of biased towards it being one. But there are other professionals that have good training in this as well.
Yeah, great. So next month we'll have another topic, if that's okay with you, Colin. I know balance was on your list.
Sure.
We'll do that, but we will have one for next month. If there are no other questions, I'm going to end the recording. Okay.